So I'm joined today by Rhidian Morgan Jones. Rhidian, thanks for joining us. And Rhidian is a knee surgeon, only does knees, exclusively knees. Rhidian, do you want to just give us a very quick intro to yourself and what you do?
Rob, thank you. Yeah, Rhidian Morgan Jones. I'm a orthopedic surgeon specialising in knees, and a large chunk of that is revision knees, but I cover the whole gamut. And my NHS practice is in Cardiff, but I began a private practice at the Shern Clinic in London, and trying to offer high-end, complex primary revision knee surgery.
So we should perhaps just explain to viewers what we mean by revision knees. Again, correct me if I'm wrong here,
Yeah.
Rhidian. It's basically where somebody's had perhaps a knee replacement and they need a second knee replacement, or perhaps even the first knee replacement, hasn't gone quite according to plan.
Yeah, that's right. So my area of expertise is taking knees that aren't working for whatever reason, and there's a half dozen reasons why things may not go well, and then resolving those problems. And sometimes you just start again. Sometimes you need to do some minor alterations to get it right. But the other half is doing complex primaries. So I see a lot of people who have post-trauma, so they've broken something, it hasn't gone well, and then you end up doing a complex first-time knee replacement in a much younger adult. So there's a whole range of complexity there,
Yeah,
as
fantastic.
well as the standard replacements and everything else.
Yeah, in the revision knees that you see, Rhidian, does there tend to be a common theme, or?
So the two commonest causes of revision in the UK are going to be infection. About 22% of revision knees are for infection. And then the next two common ones are loosening, the bonding to the bone fails, largely later on,
Yeah,
or instability, the tension of the ligaments isn't quite right.
right.
There are several minor reasons behind that: fractures, extensor problems, stiffness.
Mm.
But the main ones: infection, loosening, instability.
Okay, just to pick up on one of those points, then you mentioned the loosening, and that's what I think another phrase for that is what we call aseptic loosening, meaning there's no infection there, but it's either the bone's starting to wear, become a little bit thin, or the cement is starting to break down. Do you have an opinion when it comes to knee replacement? Do you have an opinion as to knee replacement? Do you have a preference for people having a primary knee replacement that does involve cementing or doesn't involve cementing?
So in common with the vast majority of surgeons in the UK, we would do cemented knees in most patients,
Right.
because we know they'll work over many, many decades, to be fair. But if you're a younger adult, you are high demand, then there are uncemented options. What you have to be careful of is that not all uncemented options are the same, and some uncemented designs, I think, work better than others. So I think you need to think about two groups: the standard group, if you like, the more elderly, low demand, pain relieving operation, and a cemented joint is brilliantly for them.
Right.
But if you're a younger adult, more high demand, more expectation,
Mm-hmm.
potentially an uncemented would be better for you to give you that demand, that activity level.
Great answer. And I think you said earlier on just now, you said that not all uncemented knees are the same. Do you have any further guidance that you could perhaps give patients if they were going down the uncemented route?
Sure. So you obviously talk to your surgeon, ask for their experience. The implant I use is based on trabecular metal, and that's a porous metal technology, so that you get genuine bone growth into the surfaces behind the implants.
Right.
And that works on fixation. But obviously, for each patient, fixation is only one issue. You've also got to work on the bearing, the range of movement it gives you, and the general stability of the implant. And different joints give you slightly different improvements in each one of those aspects.
Right. Are you allowed to give us the name of that one that you mentioned, the porous metal?
So it's by Zimmer Biomet. It's called the next
Right.
generation trabecular metal, TMT. Yeah.
Okay. Excellent. Yeah. Fantastic. Do you have an opinion in terms of joint preservation, let's say, in terms of, trying to offset that need for that knee replacement in somebody who's got this, cartilage damage and cartilage issue? Do you have an opinion? It's a hot topic these days and often keenly debated in terms of things like PRP injections, hyaluronic acid injections, those sort of biological type stuff. In your experience, do you have an opinion? Are they worth trying? Are they not worth trying? They can be quite expensive, but on the other hand, they're non-invasive. If somebody's got the cash, should they splash it? Should they not? What's your opinion?
So I think it comes down to two broad schools: mechanics and biologics. So if you've got a mechanically malaligned joint, so you're a bit bowed or knock-kneed, then the mechanics need to be corrected.
Mhm.
And then you start talking about maybe osteotomies or braces. So you break and realign the leg, or apply a brace outside to do that correction for you.
Mhm.
If you've got good alignment, then you can start talking about biologics. And the simplest biologic, and the one with the most experience, is going to be a steroid injection. Very, very common, very safe. But beyond that, now we're trying to get some healing potential in the knee joint. And provided the wear is not extensive, then you can start thinking of hyaluronic acid injections,
Mhm.
platelet-derived growth factors, PRPs.
Mhm.
But on top of that, and something we probably don't do enough of as surgeons, is maximize the physiotherapy,
Mm.
rehabilitation,
Mm.
muscle recovery.
Mm.
So I see my job as a surgeon, if I'm not going to operate, if I can produce pain relief with an injection, to give a window of opportunity for the patient then to engage with the physio and do the exercises. Because any injection will give you a window. And if you don't use that then to rehabilitate, get the muscle strength back, then you're going to get in recurring circles. It'll come back again a little bit.
Yeah.
But yeah.
I was going to say that you just touched on a really, kind of interesting topic there with regards to the rehab side, and something that I obviously get involved with patients myself as a sort of manual physical therapist who runs several clinics. And there's often this balancing act, as you rightly said, between you want to get that joint stability back, you want to get their muscle strength back. That involves exercise, but that then exercise involves loading the knee and as well. So, in terms of exercise selection and getting it right, that can be sometimes quite a tricky equation. People, and especially depending on patient choice and some preferences. So for example,
Yeah.
you'll have people who are keener, let's say, on the high impact things like the running and the CrossFit and various other things, and aerobics, and obviously you try to steer them away for that impact loading.
Yeah.
And you're going to encourage them to go more down the route of slower controlled activities. Now, one of the debates I sometimes have with knee surgeons is let's just say something simple like squatting movements.
Mm.
And there's often debate, well, in personal training circles there'll be the debate, well, if you do a squat, the lower you go, the higher activation of the quads, the better muscle strengthening, the better muscle building effect you're going to get. But on the flip side is you then got increased load on the joint itself. Particularly, if you go into a deep squat, I think the idea is that the femoral condyles reduce in size in that deep squat position, and therefore the point loading on the tibia increases.
Yep.
Do you have a kind of thoughts on that issue?
It's a tricky one, isn't it? I think it's a very good point, because squats are good exercises. They're good for your core, they're good for your quads. So it's an important exercise to be able to do.
And it's functional.
Maybe
Well, going out of a chair, going upstairs, it's an everyday activity.
It's a functional exercise, but it's an endpoint. And I think if we go into deep squat exercises early on, when the muscles aren't there, the knee's still a bit inflamed, they're still recovering from surgery or injections, get over the acute phase, then you run the risk of aggravating it. So I tend to ask my patients and the therapists I work with to concentrate in the acute recovery phase on dips. And by that I mean 30 degrees.
Yeah.
Don't go below that.
Yeah.
Just activate the quads, build up some resilience, and then progress. So that you get into deeper squats as your muscles recover, the knee gets calmer, and then you can progress. If you think that deep squats is your starting point, we often find patients just come back and say, oh, it's too painful, I can't do it. And they may not do that exercise, but then they probably give up on all the other exercises as well.
Yeah.
So it's the psychology of managing rehab. So dip early, get some quads recovery, and then progress to do more.
Yeah, and I think the message should also try and be, try and do that. It's very hard to manage your own recovery without having that other person there to be kind of objectively giving you feedback and giving you ideas. And I even know this as a therapist myself. It's impossible. What the advice that I give myself is different to what advice I give my patients because you just your own kind of whatever psychology takes over. So I think it's important for people to put themselves, even if they know everything, even if they know all the do's and don'ts, I think it's good to be under that guidance of somebody who can just think.
I agree totally. And it's been interesting this last year we've all been in lockdown, and both clinic appointments and rehab appointments have been a lot of online stuff.
Mm.
It's good. It's not as good as face-to-face.
Yeah.
And I certainly see patients coming back who are not what I'd expect them to be. You know, they've had some virtual physio, but it doesn't get them where they should be, because that personal contact, the face-to-face, the encouragement, seeing them truly trying to exercise and getting something wrong, it's much
Yeah.
harder to correct online than
Yeah,
face-to-face.
much harder, so much harder, as you say. You know, and you know, you can look in the mirror yourself at home. You can think, I'm doing it right, but unless somebody's looking at you from behind, the side, on top, even sometimes, you know, there's aspects you miss out. So that's
Completely. And it's that soft knowledge you get by just being in the same room with somebody.
yeah, 100%. Another aspect that's often debated in you know, knee surgery planning is things like the robotic surgery versus non-robotic surgery. Now, again, correct me if I'm wrong here, and this also relates into things like bespoke knees. So, you know, the conformists and other ones that do, you know, 3D printed knees essentially. And I think I'm right in saying, again, correct me if I'm wrong, if I got this wrong, but with the bespoke knees, that doesn't allow for robotic assisted surgery. Is that right?
That's right. So the issue with robotics is that all the major companies have robot systems, but they're all designed to put their implants in.
Yeah.
So you're then committed to go down one route to use one implant. And hopefully it'll evolve with time, and surgeons are quite innovative, and they will actually take a instrument, be it a standard instrument or a robot, and they will evolve it for their surgical techniques. But at the moment, you know, if you use a robot, you are committed to use that company's implant. It's just the way it is.
Yeah.
And for the majority of patients, that's absolutely fine. But around the edges, there are people who are maybe younger, more high demand, who need more stability in the knee, who need something a little bit different. And that's where you lose the advantage of the robot, if you know, but you gain the advantage of a special implant if it's patient-specific surgery you're trying to perform.
And when you say space, are you literally talking about the bespoke knees? You know, the things like the conformists and those.
So I think it's important to realize that every single knee will be bespoke up to a point in terms of, you know, when we do the operations, it's going to be sided right or left.
Yeah.
It's going to be a range of sizes for the tibia, for the femur. There's a range of sizes for the bearings. The bearings can be retaining, they can be sacrificing. So we can individualize the implants now for every patient.
Okay.
But the true bespoke ones then allow you to differentiate between ligament tension, medial and lateral. The sizing's a little bit different, a little bit more in tune with the patient's anatomy. On the downside of the major companies who have maybe 6 different sizes, there'll always be patients who are not a 2 but 2.5.
Right, they're in between somewhere. Yeah.
Yeah. So there's always, and it's generally, you know, women in particular. I think most knees are designed by men and therefore fit the male shape. So I think, but there are moves now to move away from that to give something that is more conforming with the joint, and a conformist would be an example of something that's state of the art at the moment.
Yeah. So do you get involved sometimes with your patient? You would use a conformist on patients where necessary yourself, or?
I don't, because my practice is very skewed, so I do a lot more complex primary rather than standard primary. So conformist and that sort of implant is really for the non-complicated knee.
Yeah.
It's for, you know, and I mean that in the right sense, because the vast majority of patients are standard, non-complicated.
Yes.
That's where we get the results. The stuff I do, often we're putting big revision implants in first time, or we're putting a hinge in because the knee's been, not only the bone, but the soft tissues have been destroyed by trauma. So it's a little bit different minutiae patients.
Yeah, the end, like you say, the real end game, the real end stage. Yeah, the complex stuff. Yeah, fantastic. So I'm guessing then, because I was going to ask you a question, but I'm guessing that you don't really get too much involved with this, but things, you know, like things like microfractures and, you know, contour resurfacing.
No, so I do, you know, I still have an arthroscopy practice. You know, it's not as big as it used to be, because as life goes on, you form a specialization in something else. But I still perform microfracture. I think that's a good, easy technique.
Yeah.
But again, mechanics. If you've got a malaligned limb, then no matter what you do inside the joint, you'll probably find you get temporary relief only.
Yeah.
So I think, you know, our understanding now is about the kinematics, the mechanics of the leg.
Yeah.
Maybe we should be performing more osteotomies, realignment procedures, so that then any biologics inside the knee have a chance to work.
if somebody has an osteotomy, for example, and this is just again as a layman, me kind of imagining what would happen to them. So I'm imagining somebody who's got 2 bow legs and they've got disease in one knee, and you're going to say to them, right, we're going to give you, I propose an osteotomy. Does that then mean that they end up with one straight knee and the original one, the other one's still bowed? Is that gross oversimplification?
Well, it depends. So if they so footballers, for example, young footballers, there's quite a high instance of bow legs in footballers, and we think it's physiological, and if you look at professional footballers, there's a much higher instance of bow-leggedness than varus knee than there is in the general population. And whether that's because they play football or because they're bow-legged, it makes you good at football, I'm not sure. So if both legs are normally bowed, we should not be trying to correct that. That's their physiology.
Yeah.
If you've got 2 bowed legs because they're very severely arthritic, then probably it's beyond the point where osteotomy would work.
Okay.
If it's a younger adult, it's a single limb, then yes, we can do it. Occasionally it'll be young adults with both sides, but normally it's going to be one leg that'll remain straight and it's the other one that's gone.
Right. And what's the recovery time for that kind of procedure? Is it a relatively quick one or not?
Yeah, so the surgery takes about 45 minutes to an hour. You're in hospital. I tend to keep mine in overnight just to observe any swelling and bleeding afterwards. But we get them up and walking. And it's a question of how much weight bearing you can put through. With most fixation systems, because you break, realign, and fix, you can put some weight through the leg, but you can't put all the weight through for something between 4 and 6 weeks. It's all about swelling. So we get them mobilizing the joint, putting as much weight through as is comfortable, protected on crutches, and then we just over 6 to 12 weeks increase load bearing and weight bearing. Okay. And normally it takes about 4 months for things to be really well healed. Sometimes it can go a bit longer, because if you break a leg surgically, it still has to heal. Yeah. And sometimes it takes a little longer than you want. So we maybe wouldn't do it in smokers or people who are significantly overweight. Yeah. It's for the younger, fitter population.
Okay. But roughly, like you say, 3-4 months until they can then start to resume their usual activities. And
absolutely. Which is a little bit longer than a good knee replacement. But the indications should be different. You're doing it for a different reason.
Yeah. Okay. Excellent. Amazing. So, okay, I was going to ask you some other questions. In terms of, do you have an opinion? Again, another sort of one is patellofemoral disease, and there seems to be a fair amount of debate as to, if and when the patellofemoral joint should be replaced, and should it be done in isolation? Should it be done as part of a total knee? Again, what's your thoughts there?
Well, I mean, if you talk about partial replacement in general, I've gone on a journey where I've stopped doing patellofemoral replacements now. And I stopped doing unicompartmental replacements a few years ago. If I see somebody who generally needs one of those partial replacements, I'll refer to a colleague. Because what we do know, and it's very important for patients to realize, is that outcome is related to numbers. And almost nobody does high volume patellofemoral replacements. There's 1 or 2 in the country, but very few surgeons do that. So I'm trying to push anybody I see to one of my colleagues locally so that they can build up an experience. And replacements, partial replacements, very, very sensitive to numbers. And because my practice is skewed to the more complex, I made a decision to stop. And again, if I see somebody who is a good candidate, I will refer on. I think it's a good operation in the right hands. But what I still do is a bit of patellofemoral work. And classically, that's somebody who's got an arthritic outer lateral facet. And they get what we call a hook osteophyte, where it starts curving over the lateral femoral condyle. So the kneecap doesn't track centrally, it's forever maltracking. If you've got a worn lateral facet and an osteophyte overhanging, you can do a very quick day-case operation just to remove that osteophyte. And that allows the kneecap to run centrally rather than being captured. And it offloads the facet. And you can get quite high return of function with that operation and a lot of pain relief.
Wow, okay, that's one I hadn't heard of. So is there a name for that procedure, sorry?
It's a lateral phasotectomy.
A lateral phasotectomy, okay. And is that done arthroscopically?
It can be done arthroscopically, but I tend to do mine through a very small mini open approach. It takes 20 minutes. Arthroscopically, it takes a lot longer. You know?
I'm guessing the visualization is better with a mini open.
It's quick and easy, and you can do a direct repair of the capsule, and it's a good thing. And then the other thing I do for young adult arthritic knees is a thing called a notchplasty.
Oh, right.
So the notch is the middle of the knee and the femur between the medial and lateral condyles. And sometimes you get osteophytes growing in to that notch and blocking it off. And that leads to contracture. And one of the reasons arthritic knees stop extending is that they can't extend because of central notch osteophytes.
Yeah.
And one of the techniques I learned 20 plus years ago when I was a trainee in Australia was the notchplasty. And if you can go in and the right patient, remove those central osteophytes on the femur and the tibia to some extent, you create space to extend into. And if you get the knee extending, then you can kick in with rehab, get your quads working.
Great. Yes.
It's very hard to get good quads if your leg doesn't extend fully.
Absolutely. I mean, and it's worth sort of mentioning to people, you know, there's particularly there's this muscle called the vastus medialis obliquus, a little portion of the inside muscle on the quadricep muscle. It has a massive function of the kneecap, you know, the kneecap gliding in the middle, and you can only get that muscle to work and when your knee's fully extending. So
exactly. So if you can get a bit of pain, get the movement back, then you've got a good chance of rehabbing.
You've got a chance of balancing everything off. Yeah, fantastic. Coming back to the lateral phasotectomy, is that again is what's the recovery time, that sort of thing?
So your full weight bearing straight away, movement as comfort and swelling allows. Normally by 6 weeks, people are comfortable in doing most things. It takes about 3 months for the muscles to fully recovered.
Yeah.
But don't forget, they start at a low point where the knee's been painful, pain inhibits muscle function and rehab.
Yeah.
So, you know, there's always a lag phase after surgery of recovering muscle that wasn't there at the start. So generally 3 or 4 months to get the best out of it. But you're doing everything well ahead of that. It's just recovery.
That's the planning. Yeah, excellent, fascinating. Where do you see this future going with knee replacements? Rhidian, do you see it going down? I mean, I think there's already improvements that have been made in the last few years in terms of things like the polyethylene, you know, vitamin infused pillow, I think high cross linked polyethylene, which hopefully gives a longer life to those plastic components. Do you see that continue to advance? Do you see different materials being used rather than the sort of the cobalts and the titaniums and going down other routes in terms of as people done with other joints, shoulders and hips, for example? You know, ceramics are coming in, pyrocarbons are coming in. Do you see the same thing happening with knees or not?
Sure. So there are already ceramic options in the knee, that's proven to reduce polyethylene wear in the laboratory. Yeah. There's no evidence yet that in the patient it improves longevity of the implant.
Yeah.
So, you know, you have to be careful because you can't actually promote it as saying it will definitely do this. But certainly in the lab, and there's good scientific reasons why it would reduce poly wear, just like ceramic hips and the heads and the hip work. You know, they reduce wear. There's no doubt about that. But against that, you've got 20-25% survive 25-year survival, 80% of knee replacements, and these were older knee replacements. So we've still got long-lasting joints.
Yeah,
it's a question of whether they'll go beyond that.
Yeah,
and so the improvements I see are going to be both in terms of the implant fixation we mentioned earlier with the uncemented, bearing surfaces, good polyethylene. Where with poly we talk about backside wear as well because the poly clips into the tray. And so that clip-in mechanism has got to be rigid to stop the poly sliding on the tray. So there's bits like that are improving constantly. But also, as surgeons, you know, we have to be honest with ourselves. You know, we talk about volume for partial replacements. The same has to be true to some extent for total replacements. So what we should be seeing are people specializing so that, you know, you don't do everything. You're going to be an upper limb surgeon, a lower limb surgeon.
Yeah.
If you're a lower limb surgeon, maybe you do primary knees and primary hips, you don't do revision, or maybe do one revision knee but not revision hip. So you start to specialize.
Yeah.
And so with numbers and experience, your results should improve.
Yeah.
But also working within networks. And in the revision knee world, we're talking about 3 tiers where we've got a hub in the middle that does all the really complex infected redo joints. We've got referral centers that do a lot of high quality work, but we refer some in. And then we've got the 3rd tier, which is what we call arthroplasty centers, who will do actually the bulk of the good for the population, because they'll be doing a lot of primary knees, uncomplicated work relatively, but high quality. And in terms of the best improvement of healthcare, I think the 3rd tier, if you want, the arthroplasty centers who are doing high volume, high throughput, high efficiency, low complication joint replacements, hip and knees, we're going to see a steady improvement in outcome, I think.
Great. Wow, fascinating, interesting stuff. Well, that's I mean, that's really really good, Rhidian. So thank you so much, and you know, I'm hopeful people will find this really really insightful. On some of the things you said, I certainly have myself. So
I think, you know, if I can leave you with one message, is that, well, there's a couple of messages that I always tell my patients. Firstly, they will never get to the point where they can't have a knee replacement. You know, they will
yeah,
not get so bad we can't do it. It's just about choosing the right implant to deal with the problem.
yeah,
And I think often as surgeons, we're guilty of rushing to that end surgery,
yes,
rushing to
yes,
replacement.
that's a good
And in the past, I'm sure I've been guilty of that as well. So I think we, you know, a key message now is to patients: you are never going to be so bad you can't have a knee replacement. I think patients
yeah,
often feel it's now or never. It's
yeah,
not always like that.
absolutely,
And secondly, there are options. We've gone through a few today, but that hopefully can avoid or at least delay knee replacements.
yeah,
And all these options should be discussed. Some will be appropriate, some won't. But
yeah.
patients deserve to be given all the options.
Yeah, absolutely. Yeah, and yeah, the message I'm kind of starting to learn from having talked to you and some of the other surgeons is, you know, as you rightly said, I think you mentioned at the beginning, you know, what's right for one is not right for another, and those two kind of categories of, yes, if you're in your 70s beyond and you're not high demand, you know, you probably want to be going down the tried and tested route and feel satisfied in that you can have a knee that's going to last you 25 years, it's going to outlive you, you know,
Yes,
more most cases,
yes,
and you probably don't want to start going down the not necessarily experimental, but the newer stuff that where the data isn't quite back yet, and we're not
yeah,
quite sure. You know, why not go for something that is tried and tested, and you're going to. Whereas, like you
yeah,
say, if you're at the other end of the spectrum, if you're in your 40s and 50s, and it's quite likely that, you know, 20 years down the line, or even less, you might then need a second knee.
yeah.
Then maybe that's when you have these debates, and you search around and you look at all the intricacies and the
Yeah, that's right. And again, this is where I think the younger adult, the more complex uh, starting point.
yeah,
Maybe those are the patients that get referred up the line to people who are doing a high volume of that type of case,
yes, exactly.
because it is more difficult and more demanding the younger the patients are.
Yeah, and the message I often say to people is, search out your surgeon in terms of, when you have your house done, you tend to get two or three builders
Yeah,
that come in and give you different opinions and different suggestions, and you probably should do the same with, with your own limbs, and look for the best option for you and
definitely. And I would always encourage patients to get second, third opinions.
yeah, yeah,
We don't do enough of that in this country. There's still a bit of deference towards the surgeon,
yeah,
I think patients need to treat it like an economic, um, you know, uh, discussion with anybody else that you might spend money on. Again, you may not be spending money on the health service, you may be spending money privately, but if
yeah,
you're going to have something done that of that importance, an operation, a big operation, you should get as many opinions as you want up front.
yeah,
And any decent surgeon will not worry about having a second, third opinion on patients they've seen.
yeah. No, I think that's a
I
really good point.
absolutely encourage that.
Yeah, no, it's very, very humble and very, very, very honest of you. So thank you for that. Brilliant. Well, look, thanks again, and we're gonna end it there. And yeah, Rhidian Morgan Jones, thank you so much.
Rob, it's been a pleasure, mate, and look forward to